Welcome to Study Neuro's Neuro Lecture Series. In this session, we'll focus on the clinical assessment of brachial plexus injuries, covering inspection, palpation, neurological evaluation, and the key special tests used in practice. We'll begin with a brief introduction and an anatomical overview to set the foundation. From there, we'll walk step by step through the physical examination, starting with inspection and palpation, then moving on to percussion and auscultation. We'll also cover a structured neurological assessment and discuss special tests that help localize the level and severity of injury. By the end of this lecture, you should have a clear understanding of the anatomy and clinical relevance of the brachial plexus. You'll be able to recognize important examination findings, identify injuries that commonly occur alongside brachial plexus trauma, and apply special tests to guide localization. Most importantly, you'll learn how to integrate these findings into clinical reasoning, prognosis assessment, and patient management. For more in-depth lectures, neuroscience updates, and clinical insights, be sure to follow us on YouTube at Study Neuro. Brachial plexus injuries are commonly seen in situations such as birth trauma and high-energy injuries, including road traffic accidents and falls. These injuries rarely occur in isolation and are often associated with damage to surrounding structures. Because the brachial plexus carries motor, sensory, and autonomic fibers, injury can result in weakness, sensory loss, and even autonomic disturbances in the affected limb. A comprehensive head-to-toe physical examination is therefore essential, with particular attention to the upper limb. Careful examination allows for early recognition of the injury, helps localize the level of nerve involvement, and provides critical information for selecting appropriate investigations and planning effective management. The brachial plexus starts with the roots from C5 to T1, which merge to form the superior, middle, and inferior trunks. Each trunk then splits into anterior and posterior divisions, which regroup into three cords: lateral, posterior, and medial. Finally, these cords give rise to the terminal branches that control the muscles and skin of the arm, including the musculocutaneous, axillary, radial, median, and ulnar nerves. Some important branches also come off along the way, like the suprascapular, dorsal scapular, and pectoral nerves, supplying key shoulder and chest muscles. The brachial plexus stands in 5 key nerves, each controlling specific movements and sensations. The musculocutaneous nerve flexes the elbow, the axillary nerve lifts and rotates the shoulder, and the radial nerve extends the elbow, wrist, and fingers. The median nerve enables thumb and finger flexion for precision grips, while the ulnar nerve powers fine movements of the hand's small muscles. Each nerve also carries sensation from distinct areas of the arm and hand. Because distal injuries produce specific motor and sensory deficits, knowing these patterns is essential for accurately localizing nerve damage. The brachial plexus begins with roots C5 through T1, which give rise to the dorsal scapular and long thoracic nerves. Injuries at this level can cause a winged scapula or weakness in shoulder elevation. From the upper trunk, the suprascapular nerve emerges, so damage here may lead to weak shoulder abduction and external rotation. Finally, the cords give rise to the major terminal nerves, the musculocutaneous, median, ulnar, axillary, and radial nerves, where injury can result in arm flexion weakness, claw hand, wrist drop, or sensory loss in their respective distributions. When examining a patient with a suspected brachial plexus injury, start by taking in the overall picture. Check how alert they are, because some patients may be fully conscious, while others might have confusion or drowsiness from head injuries or shock. Pay attention to how they look and move. Trauma often brings obvious discomfort or pain, and in some cases, there might be a deeper nerve-related pain that isn't obvious at first. Notice if they're using supports like slings or cervical collars, as these can tell you a lot about what the clinicians are already concerned about. Skin color and temperature can reveal hidden problems. Look for pale areas or bluish tones in the affected arm, which can suggest that blood flow is compromised. Comparing both arms for warmth and color helps identify subtle circulation issues. Finally, don't forget the lungs and oxygenation. Shortness of breath or bluish lips and tongue may signal an associated chest injury, like a pneumothorax, which can be life-threatening if missed. By observing these general signs first, you set the stage for a focused and safe assessment of the injured limb. When evaluating a patient with a brachial plexus injury, vital signs are an important early clue to their overall condition. In an isolated injury, these measurements are usually within normal limits. However, any abnormalities often point to additional trauma or complications. Keep an eye on the blood pressure and pulse. A fast heart rate or low blood pressure may indicate significant blood loss or shock, particularly if there's vascular injury nearby. The respiratory rate and oxygen saturation are equally important. Rapid breathing, low oxygen levels, or visible respiratory distress could suggest a chest injury that needs urgent attention. Temperature is typically normal in acute brachial plexus injuries, but a fever may develop if there's an infection, whether from chronic wounds, pressure areas, or after surgery. Monitoring these vital signs helps you identify hidden problems early and guides the next steps in management. Inspection is the first step in examining a patient with a brachial plexus injury. It involves carefully observing the affected limb and the patient as a whole, even before any hands-on assessment. Often, just by looking, you can get valuable clues about the level and extent of the injury. Make sure to view the limb from multiple angles, front, back, and side, and always compare it to the unaffected side to spot subtle differences. A thorough visual assessment sets the foundation for the rest of the examination. When inspecting a patient with a brachial plexus injury, pay close attention to the posture and attitude of the upper limb. You may notice that the arm rests in an unusual position, sometimes held close to the body, rotated inward, or hanging loosely. The forearm might be pronated, and the wrist or fingers can show flexion deformities. Always compare these findings with the unaffected side to detect subtle changes. Look out for classic deformities that can help you localize the injury. The waiter's tip posture is a hallmark of upper trunk involvement, affecting C5 and C6. A clawed hand often indicates lower trunk injury, involving C8 and T1. In severe cases, the entire limb may appear flail, suggesting a complete plexus injury. Fixed joint positions can also point to chronic denervation. Assessing muscle bulk is a key part of evaluating brachial plexus injuries. Look for areas of flattening or hollowing around the shoulder, such as the deltoid or the supraspinatus and infraspinatus muscles. In the hand, wasting of the thenar and hypothenar eminences or the interossi muscles can create visible gaps between the metacarpals. Forearm muscles may also show atrophy. These changes are important because they not only indicate that the injury has been present for some time, but they can also help you determine which part of the brachial plexus is affected. When examining a patient with a brachial plexus injury, observe the position of the shoulder and scapula. The shoulder may appear drooped, and the usual contours can be lost. Scapular winging is another key sign, often indicating involvement of the long thoracic nerve. Check for asymmetry between the clavicles and scapulae, as this can provide important clues about the level of nerve injury. Skin changes are equally important. The affected limb may have glossy, dry, or shiny skin, and you may notice color changes, such as pallor or cyanosis. Swelling of the hand or arm can occur, and these findings may reflect underlying sympathetic nervous system dysfunction. When examining a patient, start by noting any surgical scars or external devices. Scars from previous procedures on the neck, clavicle, shoulder, or chest can provide important clues about past interventions. Also, pay attention to any slings, splints, or orthoses the patient may be using, as these often indicate ongoing support or protective measures. Next, observe for involuntary movements. Small muscle twitches, known as fasciculations, can suggest a lower motor neuron injury. Additionally, abnormal postures or tremors may point to underlying neuromuscular issues that require further assessment. Finally, look for signs of associated injuries. Bruising or swelling around the neck, clavicle, or shoulder may indicate trauma, while obvious deformities can hint at fractures of the clavicle or humerus. Don't overlook open wounds or burns, as these can complicate both treatment and recovery. When examining the autonomic function of a limb, subtle changes can be very telling. Look for variations in skin moisture. Some limbs may appear unusually dry, while others may sweat excessively. Temperature differences between the affected limb and its opposite side can also signal autonomic involvement. Additionally, pay close attention to the nails and skin. Changes in their appearance, texture, or growth, often referred to as trophic changes, can provide important clues about underlying nerve or vascular issues. When assessing the musculocutaneous nerve, changes in the upper arm are key. You may notice a loss of the normal contour of the anterior arm, with wasting of the biceps and brachialis muscles. This often causes the arm to rest slightly extended at the elbow, and the forearm may show a reduced ability to supinate. For the median nerve, focus on the hand. Wasting of the thenar eminence can flatten the palm and impair thumb opposition, leading to what's commonly called an ape hand deformity. The index and middle fingers may also remain extended even when the hand is at rest, reflecting the underlying motor loss. Palpation is a structured, hands-on part of the physical examination that builds on what you've already observed during inspection. It helps confirm visible findings and, just as importantly, reveals abnormalities that aren't apparent from the surface. Through palpation, you can better distinguish a nerve injury from musculoskeletal or vascular causes of the patient's symptoms. Begin by assessing temperature, comparing both limbs for differences in warmth or coolness. A noticeably colder limb may raise concern for vascular compromise or altered sympathetic function. Next, evaluate for tenderness along key regions, including the neck, supraclavicular area, clavicle, shoulder, arm, and axilla. Localized tenderness in these areas can point toward an underlying fracture, a hematoma, or a traction-related nerve injury. During palpation, carefully identify key bony landmarks such as the clavicle, acromion, humeral head, and the spine of the scapula. Any irregular step-offs or a gritty sensation, known as crepitus, may indicate an underlying fracture or joint dislocation. Next, assess muscle tone and consistency. A flaccid muscle often points toward a lower motor neuron injury, whereas increased tone may suggest upper motor neuron involvement or developing spasticity. Be systematic in your assessment, examining major muscle groups including the deltoid, biceps, triceps, forearm muscles, and the intrinsic muscles of the hand. As part of palpation, assess muscle bulk to confirm any wasting seen during inspection. Always compare both sides, as asymmetry can help localize the extent and severity of nerve involvement. Next, gently palpate along accessible nerve pathways, such as the ulnar nerve at the elbow. Localized tenderness or a thickened nerve may indicate neuritis or nerve entrapment. Be alert for any swelling or masses, including hematomas, abscesses, enlarged lymph nodes, or areas of callus formation. These findings are important because they can exert pressure on nearby nerves and worsen neurological deficits. Finally, don't forget the vascular assessment. palpate the radial and ulnar pulses, check capillary refill time, and remain vigilant for signs of associated vascular injury, which may coexist with nerve trauma and influence management. Percussion adds valuable information to inspection and palpation, especially when evaluating for secondary injuries. Its role becomes particularly important in high-energy trauma, such as motor vehicle accidents, fractures, or penetrating injuries, where associated thoracic damage is more likely. Through percussion, you can help identify important chest complications. A hyper-resonant note over the chest raises concern for a pneumothorax, while a dull note may point toward a hemothorax or pleural effusion. Localized tenderness when percussing the ribs can also suggest an underlying rib fracture. Percussion is also useful in nerve assessment through Tunnell sign. When gentle tapping over a nerve produces tingling, paresthesia, or an electric shock-like sensation in its distal distribution, it provides a clinical clue to nerve regeneration, partial nerve injury, or ongoing nerve compression. Auscultation is an important final step when assessing patients with suspected brachial plexus or shoulder trauma. Begin by listening carefully over the supraclavicular and infraclavicular regions. Then, systematically examine the chest wall and the back. Pay close attention to key abnormal findings. A bruit heard near the clavicle or in the supraclavicular fossa may indicate injury to the subclavian or axillary artery. Reduced or absent breath sounds on one side of the chest should raise concern for complications such as a pneumothorax or hemothorax, often related to associated rib or clavicular trauma. When performing a motor examination of the upper limb, we focus on the key myotomes as defined by the Asia guidelines. For example, elbow flexion tests the biceps at C5, wrist extension examines the wrist extensors at C6, and elbow extension evaluates the triceps at C7. Moving distally, flexion of the distal phalanx of the middle finger checks C8, while little finger abduction assesses the hand intrinsics at T1. Each muscle group should be tested using the Modified Medical Research Council, or MRC, scale, which grades strength from 0 to 5. Start by comparing the affected limb with the opposite side for reference. Grade 0 indicates no contraction, while Grade 1 shows only a flicker or trace contraction that can be seen or felt. Grade 2 reflects active movement with gravity eliminated, and Grade 3 is active movement through full range of motion against gravity. Grade 4 represents movement against resistance and is subdivided into slight, moderate, or slightly more than moderate resistance, while Grade 5 is normal strength against full resistance. If a muscle cannot be tested, it is recorded as not testable. This structured approach allows you to pinpoint the level of injury, quantify weakness, and track recovery over time. This table summarizes the key segmental muscles of the upper limb, their actions, and associated reflexes. Starting from C5 and C6, we assess the deltoid and biceps, which control arm abduction and elbow flexion, respectively, with the biceps reflex providing additional information. At C6, wrist extension tests the extensor carpi radialis, along with the supinator reflex. C7 involves the triceps and extensor digitorum for elbow and finger extension, accompanied by the triceps reflex. Distally, C8 controls finger flexion through the flexor digitorum profundus, while T1 governs fine hand movements, such as little finger abduction and thumb adduction. Examining these muscles systematically allows us to localize nerve root function and identify deficits efficiently. Reflex testing plays an important role in localizing brachial plexus injuries. For instance, changes in the biceps reflex often point toward involvement of the upper trunk and suggest dysfunction of the musculocutaneous nerve. In contrast, a reduced or absent triceps reflex usually indicates a lesion affecting the radial nerve or posterior cord involvement. When the lower trunk is involved, reflexes related to finger flexion can also be impaired. In severe cases, such as a complete brachial plexus injury, reflexes throughout the entire upper limb may be absent. To interpret these findings consistently, deep tendon reflexes are graded using a standardized scale. No response represents the lowest grade, while normal reflexes fall in the mid-range. Brisk responses indicate hyperreflexia, and rhythmic repetitive contractions, known as clonus, represent the most severe end of the spectrum. This grading system helps clinicians quantify reflex changes, localize lesions, and monitor recovery over time. Sensory examination helps us map out how the nerves of the upper limb are functioning. We assess both dermatomal and peripheral nerve distributions, focusing on how the patient perceives touch, pain, temperature, vibration, and joint position. Light touch is tested with a soft brush or cotton wool across the skin, while pinprick or a neurotip checks pain sensation. Temperature perception is evaluated by asking the patient to distinguish warm from cold stimuli. Vibration sense is assessed using a tuning fork placed on bony prominences, and proprioception, or position sense, is tested by moving the fingers or wrist and asking the patient to report the direction of movement. Sensory testing in brachial plexus injury relies on understanding key upper limb dermatomes. The C5 dermatome is assessed along the lateral aspect of the antecubital fossa. Moving distally, sensation over the dorsal surface of the thumb corresponds to C6, while the middle finger represents C7. The dorsal surface of the little finger reflects C8 function, and sensation along the medial or ulnar side of the antecubital fossa is supplied by T1. Sensory findings are then graded to standardized documentation. An absent response is recorded as grade 0, partial or altered sensation as grade 1, and normal sensation as grade 2. If an area cannot be reliably examined, it is marked as not testable. Using this structured approach allows for consistent assessment and accurate tracking of sensory recovery over time. Sperling's test is a useful clinical maneuver when cervical root compression is suspected. To perform the test, the patient's neck is gently extended and rotated toward the symptomatic side, and light downward pressure is applied. A positive result occurs when this reproduces the patient's arm pain or tingling, rather than just local neck discomfort. When positive, Sperling's test supports cervical nerve root involvement and can suggest a pregangliomic source of symptoms. The upper limb tension test, also known as the brachial plexus tension test, evaluates abnormal tension within the neural structures of the upper limb. The arm is positioned in a standardized sequence that progressively loads the nerves, and the test is considered positive if it reproduces the patient's typical radiating pain or tingling. A positive response suggests irritation or traction involving a nerve root or the brachial plexus. To bias the median nerve, the shoulder is abducted and externally rotated, with the elbow, wrist, and fingers fully extended. Reproduction of symptoms along the forearm, palm, or the first 3 fingers points toward median nerve or upper plexus involvement. For the ulnar nerve, the shoulder remains abducted and externally rotated, while the elbow is flexed and the wrist is extended in a tray-holding position. Symptoms along the medial forearm or the ring and little fingers suggest ulnar nerve or lower plexus irritation. When testing the radial nerve, the shoulder is internally rotated and depressed, the elbow is extended, and the wrist and fingers are flexed. Pain or paresthesia over the posterior arm or dorsum of the hand indicates radial nerve or posterior cord involvement. When evaluating brachial plexus injury, always assess other systems for associated trauma. Check the cardiovascular system for signs of poor perfusion, diminished pulses, or bruits that may indicate vascular injury. Examine the respiratory system for chest wall asymmetry, tenderness, crepitus, or reduced breath sounds suggesting thoracic injury. Finally, assess the musculoskeletal system by palpating the clavicle, scapula, and proximal humerus, evaluating shoulder stability, and checking the spine for vertebral tenderness. To wrap up, a careful physical examination is essential for accurately pinpointing the site of a brachial plexus injury and spotting any related trauma. Techniques like inspection, palpation, percussion, auscultation, and specialized tests all work together to give a complete picture. Recognizing the pattern of deficits is key. This helps differentiate between upper versus lower trunk injuries, as well as complete versus partial involvement. Early identification of associated fractures or vascular injuries can significantly improve patient outcomes. Finally, combining your clinical findings with imaging and electrophysiological studies ensures the best approach to management. Thanks for watching. Don't forget to like, share, and subscribe to Study Neuro for more clear, high-yield neuro content every week. Share your key takeaway below and stay tuned for more neurosurgery made simple.